My name is Mirvat Alasnag, and I'm here with catheterization and cardiovascular interventions. This is our first episode of Statistics 101, and I have a fantastic faculty here with me that is going to join us in this discussion where we're hoping it's going to be educational. We're going to learn about study designs. We're going to learn to dissect them and do a little bit of critical appraisal and where to move with it. So without any further ado, I will introduce our faculty. With us is Professor Jan Thijssen, and he is from the Department of Clinical Epidemiology and Biostatistics from Amsterdam, Netherlands. With me also is Professor Stephan Windecker, who is from the Department of Cardiology, Bern University, Switzerland, and Professor George Dangas, who is from Mount Sinai, New York, United States of America. So my first question really is directed to you, Professor Windecker. Could you just briefly describe the design of the trial that we're going to discuss today, which is really the 2-year clinical outcomes after successful transcatheter aortic valve implantation with balloon expandable versus self-expanding valves? And of course, this was a sub-analysis of the GALILEO trial.
So, sure, thank you for the opportunity to join this discussion, and I'm happy to point to the study design of the GALILEO trial, which importantly was the first randomized clinical trial that compared 2 different anti-thrombotic therapy regimens in patients undergoing transcatheter aortic valve implantation, importantly in a clinical setting without an indication for oral anticoagulation. So the design was an open-label, multi-center, event-driven randomized controlled trial that compared in rivaroxaban-based antithrombotic strategy versus an antiplatelet-based strategy. And importantly, as I already mentioned, these patients did not have an indication for oral anticoagulation, and they had to have had a successful TAVI intervention. That is, the intervention was finished with proper functioning of the prosthesis and without major adverse events. And then patients were randomly assigned to 2 arms within 7 days of the procedure. And the 2 arms were one, that was the experimental arm, consisting of low-dose rivaroxaban, 10 milligrams once daily, plus aspirin in a dose of 75 to 100 milligrams once daily for 3 months, followed by a rivaroxaban monotherapy for the remainder of the trial. And the control arm consisted of what was then the routine regimen of dual antiplatelet therapy, that is aspirin 75 to 100 milligrams q-day and clopidogrel 75 milligrams q-day for 3 months, followed by aspirin monotherapy. I just highlight the issue of the dual antiplatelet therapy because the trial was designed at a time where the popular TAVI trial results were not available at that time. And the trial had 2 endpoints that were of interest. The primary efficacy endpoint was a composite of death, stroke, myocardial infarction, systemic thromboembolism, symptomatic valve thrombosis, or deep venous thrombosis or pulmonary embolism. And the primary safety endpoint of this study was WARC-2, major disabling or life-threatening bleeding. The trial was powered or designed for superiority for the primary efficacy endpoint.
Well, thank you. And I'll turn here to Professor Thijssen. So the trial was terminated early. So the GALILEO trial itself was terminated early in August 2018. After the efficacy cutoff date, 42% of those planned, the 440 patients, reached the primary efficacy outcome with no plan for an interim analysis. Could you explain to us how you're able to extract meaningful outcome results given the early termination and the small number of patients that you ultimately ended up with?
So the statistical design of the study, and maybe it's important to repeat it right here. So when we designed the trial, we thought that the 18-month event rate would be 33%, and that the rivaroxaban-based regimen would be associated with a 20% relative risk reduction. So a positive effect, 20% fewer events in patients in the rivaroxaban regimen compared to the DAPT aspirin control arm. So this power calculation, and the study was event-driven. That means that the trial in principle continues until we have the number of patients, in this case 440, with a primary endpoint. Originally, we planned to include around 1,500 patients. In the course of the trial, we already saw that the high event rate was probably not going to materialize. So we were already thinking about how to deal and how to get to these 440 patients needed to show a 20% reduction in the primary endpoint, the composite primary endpoint. Professor Windecker just mentioned all the components of the primary endpoint. So in August 2018, the data, so in every trial, there is a data safety monitoring committee, not so much to see whether there is early signs or whether there are signs, information about early efficacy, but to keep an eye on the safety of the experimental patients. And safety here could be an increased bleeding rate, an increased mortality rate, but also an inversion of the primary endpoint. More primary endpoints, the ischemic, basically thrombotic primary endpoint in the rivaroxaban group when compared to the control group. So when the trial was terminated early, the Data Safety Monitoring Committee observed the opposite of what we expected, namely more thrombotic events in the rivaroxaban arm than in the control arm. And then they recommended to stop the trial. Of course, this was taken over and implemented by the steering committee, and the treatments and trial treatments and collection of data, of endpoint data, was terminated at a date somewhere in the fall of 2018. That's the end of the trial. You're right, we had much fewer events than we anticipated, but the outcome, the distribution of the events over the two treatment groups was inverse of what we expected. So if you look in the New England paper, you can see that the primary endpoint occurred 35% more frequent in the control arm with a p-value just under 0.05. That was basically the trigger for the early termination. So this whole idea of 440 patients needed to show 20% event reduction, you can throw it out of the window, by way of speaking. The whole statistical analysis plan was written and designed for an efficacy outcome close to what we expected in the trial. And here it was different. You can see a 35% more event rate is a much higher event rate than 20% reduction. And that's why we could publish the trial. We had a long discussion with the New England Journal about it, with a p-value, with an ordinary p-value, which was below 0.05. So that's basically the answer. The effect was negative and larger, 35% increase than the assumption for reduction for which the trial was powered.
Well, thank you for clarifying that. And another point that perhaps warrants clarification as well is that at the end of the day, this was a post-hoc analysis of a randomized trial where the selection of the transcatheter valve, heart valve, was based at the discretion of the individual center. Yeah. So how can we adjust for the inevitable confounders, such as preferential selection of a self-expanding valve in a small annulus?
Yeah, so basically the type of THV device was clinical practice, basically the devices were already placed before the patients were asked for informed consent and were entered into the trial. So when we compare the two types of valves, this is basically clinical practice. So it depends a little bit whether you have sites who do the one or sites who do the other all the time, then probably there isn't that much selection, but there are also sites probably that do sometimes the self-expanding and sometimes the balloon expandable device. In an observational study, that's basically the data that you have. You can see it in table 1 of the publication in CCI, and there are some differences, not that many differences. Most of the p-values are, most of the differences are small with non-significant p-values, but there's a slight increase, slightly higher Euro score and STS score, I think, in the balloon expandable group. In table 2, you see the crude hazard ratio. That's the relative risk disregarding any differences in baseline characteristics. And in the right column, you see a multivariate adjusted analysis, and those are basically the same. So it really means that there is not a real difference in the patient profiles. And I'm not a clinician, I'm a statistician, but the difference in the Euro score and in the STS score is statistically significant, but as far as I understand, clinically not very large. So the patients groups, ordinary clinic practice are quite comparable, and that's why the ordinary, the unadjusted relative risk estimates, hazard ratios are virtually identical to the adjusted ones. So basically, the adjustment takes care of it, but there was not very much to take care of because the groups were reasonably comparable.
Well, thank you very much. So here I'm going to move to the clinician now. So I'll go to Professor Windecker and ask you if you could just tell us the most important results from the GALILEO sub-study that compared sapien balloon expandable versus both core valve and Evolut self-expanding valves.
Sure. So first to point out what Jan Thijssen already mentioned, this is a post-hoc analysis. And importantly, all sites were allowed to use approved TAVI devices, either FDA approval or CE approval. But as it turned out, the vast majority of patients, approximately half, were treated with a balloon expandable sapien valve, and 1/3 of patients were treated with a self-expanding core valve prosthesis. Now, what is also important to recall is that this analysis was done based on the design among patients that had undergone successful TAVI. So at variance with a head-to-head comparison of trials where you would randomize prior to the intervention, these actually were successful TAVIs within hours or days after the intervention, which is important in the overall interpretation of the data. Now, there were two major data sets that we looked at. One was the clinical outcomes, and the other were the hemodynamic outcomes. Maybe I'll start first with the clinical outcome, and that showed during a follow-up throughout 2 years that for a composite outcome of the primary efficacy endpoint that I had mentioned earlier, but also other more commonly used composites like death and stroke, and also the individual endpoints, mortality, stroke, myocardial infarction, and bleeding, that there were no significant differences between the groups in adjusted analyses. Looking at the hemodynamic endpoints, however, there were differences in the sense that the frequency of mild to moderate paravalvular regurgitation was higher with the self-expanding core valve prosthesis as compared to the balloon expandable sapien prosthesis. Conversely, what we also noted was that the hemodynamic pattern in terms of aortic valve area, effective orifice area, and the transvalvular gradient were more favorable for the self-expanding prosthesis as compared to the balloon expandable prosthesis. So these were the major findings of this sub-study.
So again, since this is really statistics 101 and we want to kind of come back to the basics, when we look at the discussion portion of the trial, of the publication itself, you do mention that the choice trial, for example, was a small randomized trial of about 121 patients with limited statistical power, but did show no significant difference at 5 years in clinical outcomes. And then on the other hand, we have a larger matched cohort from the France TAVI registry with 3,900 plus patients in each arm that noted a higher rate of paravalvular leak and 2-year mortality with self-expanding valves. So how do we interpret results from smaller randomized trials and then those from larger observational trials?
Yes, that's an excellent question. And, you know, as usual, we need to look at the entirely available evidence, with the highest level of evidence being derived from randomized clinical trials, but importantly, also how these devices are used in clinical practice. Now, there have been actually 2 randomized clinical trials, choice. There has been another one, 𝔼𝕡𝕚, and they both showed in short term for choice and 𝔼𝕡𝕚, but also longer term, 5 years for choice, that there were no significant differences in terms of the clinical outcomes. I think these findings are somewhat echoed also by the similar outcomes if we compare the major pivotal trials comparing TAVI versus surgical aortic valve replacement. There have been kind of mirror image trials in the high risk, intermediate risk, in low risk TAVI populations, comparing the balloon expandable and the self-expanding prosthesis against surgery. And the results are largely consistent. And if you perform a meta-analysis, and this now includes up to 9,000 patients, then actually the device type does not play a major impact. Now, what does it mean as it relates to the observational study France TAVI? I think there we also need to recognize that more frequently in the overall population, the balloon expandable TAVI prosthesis was used. So there was more experience, or for some reason it was used more frequently, indicating that probably the patient populations were not exactly the same. The second one is that the inclusion period in France 2 was a time interval from 2013 to 2015, which indicates that a previous generation of prostheses were used that are now superseded by newer generation devices. I think this is also something that is important to consider. And then finally, we need to think that the observational studies remain limited by residual factors of confounding, that is unknown biases that are not known. I think in that context, it's very important to point to randomized clinical trials that directly head-to-head compare these prostheses. And there are some trials ongoing, and really these are the ones that should give the definitive answer. From a clinical point of view, I just would conclude with one more remark, and that is that there are certain anatomic settings where you may prefer one valve type over the other. So if performing a randomized clinical trial, I think there will be always patient populations where you would prefer one valve over the other, but certainly there is a large area of overlap where you would use to an equal, where you could use either device, and that's certainly where a randomized clinical trial should take place.
Well, certainly, thank you for putting it into clinical context, because ultimately it says, what I understood from this trial is that if you leave it to the discretion of the operator or the center, the results are comparable. So, individualize the decision making.
Yes.
Yeah, but there is one important element with this group of patients, and Professor Windecker already referred to that. So the complications of TAVI also occur immediately after TAVI, and these patients are selected to be eligible for the GALILEO trial. So the TAVI itself already needed to be successfully completed before patients entered into the GALILEO study. So that's an important consideration here in the outcomes of the trial.
Absolutely, thank you. So at this point, I'm going to turn over to Professor Dangas and ask you, we just heard the results of the sub-study from the GALILEO trial. Why aren't there any larger randomized date trials with head-to-head comparisons? And do we actually still need them in 2022?
Well, it's a great question, but it's always a little bit of a problematic to get them up and running and funded in adequate numbers. And also, we have new devices coming up. So, how do you reconcile that? When you start a study, by the time it's ended, there's a new generation of a device. In general, one can say that we do need more studies, no question about it, particularly comparing the self-expanding, supraannular, perhaps, position than the balloon expandable intraannular in some ways, because it's not just a device, just I would say, a method of placing the new valve. We always look forward to some of those investigator-initiated opportunities and some broader international collaboration to get those things up and running.
Perfect, thank you. And, just one final question that I have, and I know it came up when we were discussing it in smaller groups, was when we look very carefully at the data from the sub-study of the GALILEO trial, we see that there was a numerically higher all-cause death and cardiovascular death with self-expanding valves, but there was also a wide confidence interval. So what do you understand from that?
Well, I understand that we don't understand. It's inconclusive. It's a signal to be evaluated together with the results from other studies or from larger trials, as we were alluding in the past. As you know, this kind of signals may be due to just variability, chance, geographic distribution, different patterns, low volume, high volume centers, or low enrolling, high enrolling centers, and clearly patient selection. We all want to say that our studies evaluated consecutive patients. For whatever logistical reason, it is never consecutive patients enrolled. And that obviously introduces some limitations to this, as well as any study, quite frankly.
So in your practice, just to kind of wrap up our discussion today, in your practice, how do you select between a self-expanding valve and a balloon expanding valve?
Well, I think is several factors inclusive of the judgment of the possible coronary disease appearing later on, and obviously this is related to patient age, risk factors, and all that. And there is some very specific CTA anatomic really considerations, limitations that would point out to a better result with one valve versus another. So it's a little bit of a mix of a clinical as well as a CT-based specific judgments, I should say.
Thank you. Well, thank you, gentlemen, for taking the time to be with us today. This was certainly very educational, and I'm hoping to reconnect with you on another episode.
Thank you.